Good evening. Thank you for joining us for introducing Central Coast Electronic Referrals. My name is Phoebe James and I'm a Professional Development Officer with the Hunter New England and Central Coast Primary Health Network. Before we go any further, I'd like to acknowledge the traditional custodians of the lands that we are all meeting on today. I am coming to you from Awabakal land and pay my respects to elders past, present, and any First Nations people joining us tonight. Just some housekeeping. This session is being recorded. The recording and the PDF slides will be available in the Education Library on the PHN website in the coming days. There will be a Q&A session at the end of the presentation, so please put your questions in the question box. Presenting for us tonight, we have Sarah Houlihan, Primary Care Improvement and Digital Health Officer with the PHN, Dr. Ellie Warren, Medical Director at Central Coast Local Health District, GP Staff Specialist, and also a GP at Your Family Doctors in Erina. There's also Siddharth Ramani, E-Referral Project Manager with eHealth New South Wales, Shiromi Gasperson, Change Manager at Central Coast Local Health District. I will now hand over to Sarah. Thanks, Sarah.
Thanks, Phoebe. I just wanted to, as PHN staff, reiterate our support for general practice around these changes and the introduction to e-referrals on the Central Coast. The great thing about the system that the New South Wales Health have gone with is using HealthLink. You've already got this available in your software, or you've got access to it via the portal, which is fantastic. You're using your existing software. It is free for you to use. And we know it's a familiar system for probably all of you through your driver's license, medicals. There's some workers' comp on there now, and in my health record referrals as well. But thanks, Sid. So HealthLink have advised us that there are more smart forms coming for GP and specialist practices that are in development at the moment. So that's really great to see that the system is evolving. Thanks, Sid. Now, of course, the RACGP has full support for secure messaging systems, being the encrypted, secure transfer of confidential patient information, being that they are the safest, most secure and most efficient communication method between health and care providers. And this is, of course, backed up by the Australian Digital Health Agency, and PHN has got their full support behind moving towards more digital technologies for the security and safety of our patients. So on the PHN website, in the Digital Health tab, you'll see that we have a new tile in there around Central Coast e-referrals. And this contains the information that you might like to find around which services are on the e-referrals, and links into the health pathways and to the Central Coast Local Health District website. In the Hunter New England Send e-referrals is the same information that you had available to you before. And it's important for us to address that these are two separate systems. If you are working in the Hunter New England, you will continue using Send as you always have. If you're working in Hunter New England and have Central Coast residents that you're referring into Gosford or Wyong, you will be able to utilise the Central Coast e-referrals for the 4 chosen specialties to start with. And if you're ever unsure of which service is best to use, which pathway to take, or whether e-referrals are available, you can refer to the Central Coast Health Pathways, which have been updated to with information around the HealthLink electronic referrals for you. I'll pass over to you, Sid.
Thank you, Sarah. Good evening, everyone. So we'll be going through a bit of an overview of the solution and a demonstration as well, and how notifications work, along with a quick introduction of the referral update feature. And then we'll talk through the benefits of e-referral and the key resources and the scope at CCLHD and then we'll have a Q&A session there. Just a bit of background on this project. The real case for change here is, as we know, fax is a technology from about 150 years ago. So we want to come to the digital age. So that was a key driver for this program, to digitize the referral journey all the way from the GP through to LA hospital end. We're working in close partnership, and the sponsor for this program is the Ministry of Health, and we're working in close partnership with the LHD and obviously the PHN as well. The key target group being the GPs, but referrers across the board that want to refer into the public health system in the outpatient setting. So just an overview of the solution, as Sarah touched on earlier, it integrates the HealthLink smartphones is the preferred solution for the state, and it integrates with all the major practice management software, and you're able to securely transmit information into the hospital using the electronic the hospital's using the electronic referral management system, and they're able to process the referral from receiving it to screening it to triaging it, and then all the way to post-triage admin. And along the way, there's notifications at different steps of the cycle, which we'll go into a bit more detail, both to the referrer and to the patient. Now I'll jump to a quick demonstration. Bear with me. So before I jump in, I just want to make a few notes there. So while we're developing these forms, we undertook a very sort of collaborative approach, and we had a participation from clinicians across the LHD, across the state, who were providing us the clinical input of what's required for each of the specialties. And also we had a panel of GPs from across the state who would provide us the information on the usability and whether there was anything that they couldn't use as features. So we did that consultative approach to make sure that it was both fit for purpose from an LHD perspective, but also, you know, user-friendly from a GP perspective, to make sure that it's a critical criteria for the success of this program. And a few other notes that this is a demo environment, so you see a lot of links in here. In your production, you'll see only the links that are relevant for your location. So, and the other thing is that when you launch HealthLink, that's when you'll come to this kind of a landing page, and then you'll be able to click into the Central Coast landing page to see which services are available. And the demo environment is also not hooked up to a practice management software, so just another call out there. So it might just look a bit different when you launch it from your practice management software there. I'll just take you through the antenatal and service there. You make a selection on the service tree and then select the facility. In this case, it's just Central Coast LHD, and then continue to launch the form. And once you launch the form, just waiting for it to load, it's fetching all the clinicians associated with that clinic, and you'll be able to select from any of the clinicians available in the list, or select unnamed referral as it's aligned with the Medicare practices. Just to call out that the main interaction is with the requested information tab. Most of the information required is in this tab. Most of the input required from yourselves will be in this tab, but you've also got these tabs along the side that facilitate most of the pre-population that we touched on earlier. So you've got the attachments and reports that you're able to select from your practice management software, or load from a local file. Then you have the medications, allergies, and alerts. which you can also select that are relevant for this referral. Similarly with the medical, social and family history, and the patient information is also pre-populated from the practice management software. And the referrer information is also pre-populated from the practice management software. This just enables to speed up the referral completion process. Then we have a look at the header information. So you got defaulted to new, updated and continuation. Then you're able to select the referral period, referral validity for 12 months, 3 months or indefinite. The referral priority, just to note that referral priority is an assessment and an opportunity to communicate the urgency from your perspective. The local health district will make an assessment on their own as to the referral urgency and priority. It's another note that if you do select rapid access, there'll be a pop-up. It's not showing in the demo system, but there'll be a pop-up to say, please associate that with a phone call. And then a patient availability for short notice at short notice, and if the patient's suitable for virtual care. You then have the Health Pathways link embedded in here, and we do strongly encourage that you use the Health Pathways to see if there's any other local criteria relevant for the referral. Then you have the reason for referral, which is if you select the reason for referral, it highlights the necessary information required for that particular referral. And since we don't want to block any referrals coming through, we ask a question if the appropriate information is available, and if not, if you select no, we just prompt you to provide a reason as to why that's not available, and then we allow you to progress through the referral. It's another call out that all the fields marked with asterisks are the mandatory field, red asterisks are the mandatory fields that need to be completed. And then here we look at referral details. Again, you're able to pre-populate this from any of the consultation notes that you may find relevant. You're able to select them and then also make updates as you require to progress the referral, be able to provide a narrative. Any other additional information that might be useful for triaging, you can provide that here. And then the preferred model of care and the other necessary information. So there's also a selection for pregnancy complications. Again, it's easily collapsible if there is no known pregnancy complications, but if there is, there's an option to select and notify what pregnancy complications there are. We've also defaulted the risks and barriers to no, and if there are risks and barriers to the patient's access for care, then upon selection, it will prompt you to provide that additional information. Otherwise, you can keep progressing with the referral. And here we've got the patient consent, where it's a consent for exchanging the information electronically from HealthLink through to the ERMS system that we touched on earlier, and also to receive SMS phone or email, or by letter contacts by any of those modes. Once you tick this, you're able to either preview and it'll note any mandatory fields that are missing in the selection. You're then also able to park the referral if you're still waiting on information and you're not ready to submit it. Or once you've completed all of the information, you're then able to submit this referral through. That brings the demonstration to a close. So I'll just quickly jump into the level of notifications. Just bear with me. So we've got notifications upon receipt. So this is automatically triggered as soon as the referral is received at the LHD. There's a notification, so if the hospital requires any additional information on top of what's already provided, they can choose to put it on hold, and in an ad hoc communication, they can and send a communication back to yourselves, which sits in your practice management software. So you get notified at those stages. The patient also gets a notification on receipt, and then at screening outcome, if a referral is not accepted for some reason, but the referrer and the patient are notified. Where there's screening outcome is accepted, it's because it's passing through to the next stage. There's no notifications there. And also there's when the triage outcome is either accepted or not accepted, you get notifications both the patient and the referrer. Then if the referral's redirected for some reason, if the clinicians deem that the care is better provided at another facility, then you get notification, and so does the patient, so that there further arrangements can be made. And if the referral is cancelled for whatever reason, the notification goes to both referrer and patient. So a bit of how the referral notifications look. So you'll see where it's coming from and what the notification is about at the referral receipt, and also when the referral is placed on hold. Again, also similarly, when the referral is being triaged or referrals cancelled for whatever reason. Just an update on the upcoming feature. So we're working very closely with HealthLink on this feature, where the GP will be able to submit additional information and retrieve the open referrals for a given patient, and you'll be able to see select a particular open referral for a patient, and then be able to send an update. So you could imagine circumstances where new information becomes available, or if the patient's condition is deteriorating or has changed or has gotten better, you'll be able to send an update to that specific referral. This really speeds up the communication and the efficiency of sending the updated information, and that two-way communication between the LHD and yourselves. So the timeline is we're targeting a webinar along with a demonstration of this feature and how it works in June 2024. So around that time, we're also targeting to go live, but we'll give you a closer update, in that webinar. I'll hand over to Dr. Ellie Warren now to talk through the e-referral forms and the helping
Thanks,
platforms.
Sid. It's really nice to see that in demo mode, because it really it makes it a lot simpler when you see it in action. And I guess just a bit of background from my end, a lot of you guys will know me from various committees and PHN webinars previously, but I'm chair of the GP collaboration panel on the Central Coast here, and we've been advocating for many years actually to have something like this that's par with our Hunter New England colleagues. We've been quite envious of their Cent e-referral system, and to see this finally come to fruition is super exciting for us. We've been involved in lots of higher level conversations to try and ensure that there was enough GP consultation to make it user-friendly, and of course there's going to be a few teething issues, but it seems like it's going to be very easy for us to use. So I guess my practice, Your Family Doctors, have been involved in a pilot trial of this on the coast just for a week before it's gone live for others. I haven't actually sent a proper referral through just yet. I've been waiting with bated breath for an appropriate patient to use the system with, but I actually was a bit cheeky and sent through a test referral this afternoon just to test the system, and it was actually very, very easy indeed. So it eliminates the need for faxes. GPs and medical professionals are one of the only professions who use fax anymore, and it's quite embarrassing, really. But the opportunity for faxes to be lost and not be as secure as we'd like, even email referrals are not secure, and that has been a big issue for privacy and confidentiality. So this eliminates the security risk, and it's that real-time transfer of all the important details, and the prompting from our LHD colleagues about what information is really important for them to make good triage decisions about when they can and they should see our patients. So it requires no changes to our existing practice software, so it's really usable directly from best practice and medical director and the other less well known systems like Genie and Helix, and it's really just as easy to use as our RMS or Transport New South Wales drivers medicals that we're all used to doing now. So the copy of the referral is actually saved in our correspondence out section for us to go back and refer to, and we get a notification back from LHD admin when the referral has been received, and so that comes directly into our results inbox here. That's a lovely demonstration there, Sid, thank you. So we're all used to seeing finding our results there. These are where the notifications come through, and that will also be where we get the prompts that our referral has been accepted, or we may need to add some further details, and we'll be able to go back in and provide some extra information. So nothing that we haven't really not used before. Those notifications I noticed today go into our investigations inbox in the patient's file, which might end up being a little bit clunky, I thought, to be mixed in with the full blood count results and that sort of thing. I'm not sure if we can reconfigure that within our practice software. But if you just go back to the e-referrals benefits slide, Sid, if you don't mind, it just makes it easy to attach results, important correspondence and results from our patient file, so that I'm often sending a referral through by Argus email, but I'll have to go back and print out the reams of results and a correspondent from specialists to fax through separately to the office, and we can attach all of that separately using that beautiful attachments and reports tab. So there's just that faster comms between hospital and primary care, and I believe there's a two-way communication function. We've had reports from colleagues who are already using this in some of the Sydney LHDs that when the referral is received, they actually have one of their LHD specialist colleagues come back with a notification of what we can be doing for our patient in the meantime. If they're going to be waiting 3 or 6 months to see the specialist, we might add something to their treatment trial of prednisone and some extra clinical details there to help us care for our patients whilst waiting for the specialist advice. And information from our colleagues, GPs who have been using this, have actually reported that some of those appointments are no longer needed when you have that bit of extra access to specialist phone a friend advice. Get that back, try this, and then they'll actually end up cancelling the appointment. So we're seeing better outcomes for our patients, improved access to specialist clinics, and really faster and better triage of prioritising patients for important clinical need versus those who can wait a little bit longer, and the way for us to feed back to our colleagues if anything changes in the meantime. If something requires escalation of triage, then we can send through those extra clinical details to bump our patients up the list. So it seems like, I mean, only good things can come of this. I think it's been a long time coming. We can buzz through just a little bit about health pathways there, Sid, if you go down through a couple of extra slides. I think there was a mention of resources for GPs, and then how we can access information about the clinics that are using this system first. Through Erica Drew is just so prolific with her updating of health pathways and making sure all of this information on health pathways is accurate. So certainly on the Central Coast, the main outpatient clinics that we'll be able to access using this system first will be PEDS, antenatal, NO&G, gynecology and neurology. And so if we go to this main health pathways e-referrals page, you'll be able to scroll down and find the links to those individual health pathways pages, and then you can directly, it's a shame I can't show you a demo, but if you then go to the low risk, say, obstetric referrals page, and here's a non-urgent gynecology assessment page. If you go to the public referrals section and contact the provider, if you open up that Gosford Hospital Gynecology tab, you'll see all of the specialists there listed who offer outpatient services, and there are a couple of them who will tell us what their special interests are. So you might know that Kelly Hankins loves colposcopies, and so if you have a special need for that subspecialist group, then you can select her name from the e-referral HealthLink form. So if we integrate what we're doing with health pathways and use it well, that just helps streamline things for the referral pathway. So I think it's really going to be important to use the new system in conjunction with health pathways, and as we roll out more outpatient clinics who are using this system, Erica from the PHN and Health Pathways team will be working overtime to keep everything up to date. So it's an amazing resource. What's the next slide there, Sid? We talk through some more detail. Yeah, so I think just to note that these were thought to be, I'm actually not sure how these clinics were chosen, but you can see they're pretty high yield from primary care GP land. We use these clinics all the time, so it's going to be a fantastic way to get the e-referral system up and running quickly. Antenatal and gynecology PEDS, I know are certainly well used referral pathways. I've actually been in contact with the neurology specialist centre today, the head of department. It's interesting that neurology was included in the first rollout, but actually that specialist centre clinic is more like a rapid access clinic for people to be referred directly through ED for stroke and other reasons, or neurology consultants to refer back into our outpatient clinic themselves if needed. So we're not pushing for a new, oh wow, the neurologists are suddenly available to GPs, but the head of department there, James Evans, has reached out and said he's certainly willing to talk to us about what's going to be most useful for GPs in terms of neuro access. So you can see that this system is already bringing us closer together, and that's the beautiful thing about these new systems. We've been working so long on the GP collaboration group locally to just help improve access for our patients and bring hospital and primary care closer together to break down those referral barriers and improve outcomes. So it's wonderful to see this coming to pass. I think that's probably the end of my section there, Sid. Is that okay with you?
I'm talking away and mute. Yeah, I think over to Shiromi now.
Thanks, Ed. Thank you, Ellie. Just with these clinics, there are some forms that you'll obviously see in your practice management software. We have a generic pediatric form, which you'll use to refer into the pediatrics service. And for gynecology, obstetrics, neurology, you'll use specialty forms that you'll see in your PMS systems. Thanks, Sid. Just to the next slide. In terms of support during the transition, we've been working closely with the PHN, so Sandy and Sarah, who have been incredible in providing some comms to our GPs throughout the district. We will continue to work with them to provide you with regular updates on the e-referral adoption and look at providing feedback on what's working, what's not working, who we can try and assist a little bit more to get onto e-referrals. And we'll be doing this through newsletters and emails and other correspondence, so please keep an eye out for those. We are trying to discontinue fax to those 4 services, those 4 in scope clinics, and really promote these e-referrals. So if there are any issues or you're having troubles setting up these forms, please do reach out. The contact details are there, or you can contact the PHN at any point, and they can redirect your query, and we'll help you set that up. One thing that we're looking at doing from the district perspective is to understand how you feel about your current referral creation and sending off process. So if you wouldn't mind scanning the QR code, there's a 2-minute survey there, and it just looks at assessing how you feel about creating a referral, attaching documents, the communication styles and methods that you've had to utilize to contact the district or contact the services if you need to follow up on a referral, looking at the time it takes for you to create a referral, things like that. And hopefully after a few months, we can re-administer this survey. And if there is a drive towards the e-referrals, we can try and compare this pre and post survey to see what you think about the actual adoption of the e-referrals and the methods. Any questions so far?
Thank you, guys. Really informative presentation. I'm not clinical at all, but it made sense to me. So we have had a few questions come through. I wanted to thank the people who have submitted them. We love questions. It's an important part of learning and information transfer. So thank you very much. If you do have any questions, please send them through now whilst I go through the current submitted ones, because it's not very often you get the opportunity of a fantastic panel like we do have here tonight. So the first question, more of an observation that I can see, is stating that it does not populate all the data to the health link, and you need to type in the next of kin details. I did flag this one with JC, so if you wanted to comment, please.
Yes, so the smart forms do populate. There's a core subset of data that the smart forms will extract from each of the different practice management software systems. There are always ongoing enhancements to that core data set, and some of the practice management softwares are a little bit faster at attending to those updates. So next of kin is a good example where I believe at the moment best practice doesn't pre-populate that from the patient record, but medical director and the other softwares do. So there's only minor variations when it comes to key data points like that. I think Sid was referring specifically, or maybe was showing specifically an antenatal e-referral earlier in the presentation, where things like the EDD and other core data fields from the pregnancy sets that you have within the patient record all do come through pre-populated. Just to give an example of, there is consistency broadly. However, there are the odd sections where that doesn't always come through. The key though to reinforce here is that if those data fields are mandatory to be submitted as part of any referral into Central Coast Local Health District or any other organisation, you will not be able to submit that referral through to those organisations without including that information. So it will be a mandatory point for you to check, not only to make sure the data is there, but to make sure it's up to date, as it may have been some time from the last time you checked whether that information was correct in terms of contact information for support people or carers and other references there as well.
Perfect.
I hope that answers the question. Yeah.
Can we still use referrals the same way and not use e-referrals? This is around referring an unnamed as first available appointment.
If I understand the question correctly, you can use e-referrals and leave it unnamed. Yes, you can do that. There is always going to be the option of having a referral unnamed. If it is to not use e-referrals altogether, we want to discourage that. We want to promote the uptake of e-referrals, but there may be circumstances where you're not able to submit a referral. So yeah, we could look at that case by case, I guess. Any comment on that, Jeremy?
I think ideally, if possible, a named referral would be recommended or preferred, at least by us from the district. From the LHD. But if you need to do an unnamed referral, that is an option within the form.
Okay. So do patients need to call the clinics or wait to be contacted?
The clinics will call patients to make appointments. Patients will also receive notifications, like Sid mentioned, throughout the referral process. So they'll be kept abreast of how the referral is tracking in terms of the different stages. So they're kept up to date as to where it is, so they don't need to call clinics. They'll call them to make an appointment. So no need to contact clinics.
Sure.
Phoebe, I might jump in there just from a GP perspective. This is one of the really great things about this system, because often we give someone a referral and express the importance of following it up, but actually find, months later that they never actually made the connection, didn't make the call. So we can see when that appointment is booked. We get notified when they've made contact with the patient. We get notified if there's any delay. It really closes the loop there in terms of safety and also medical legal responsibility. If we think it's important enough to refer someone off, we need to make sure that they go, and there's a process to check that's been done. So I think it's a great thing.
Sure. Next question is, you're not able to delete a started form. Is there a reason for this?
I think you can discard the form halfway through. JC, chime in if I'm saying that incorrectly. So if you don't progress to submit, you can simply exit the form, or park it if you do wish to save the details, save you from repeating again. So there is that option, is my understanding.
Yeah, there are built-in features directly into the operation of the SmartForms interface. So, and some of those are key, that they don't change per the other SmartForms that you use as well for any other organization. So those standard controls remain in place. The SmartForms themselves can only be accessed from within the specific patient record that you've accessed. If that referral it needs to be discarded, does not need to be continued, that's saved as a record, and I believe it can actually be marked as not required or deleted.
Right. Okay. Is this an evolving process? Will the forms be updated if feedback from GPs state that some things are too onerous or people are consistently entering erroneous data?
Yes, absolutely. Yeah, we intend to, there's a feedback link in the New South Wales Health. You'll see in the resources, there's a feedback link embedded there. So you have the opportunity to provide us the feedback, and we'll constantly work with HealthLink and the LHD and the GP panel that we have to ensure that it's updated. So we'll continue to have that consultative approach to make sure that it's working for everyone.
That's good to hear, Sid. From our service within LHD, I help run the Hospital in the Home service, which is a new and expanding service on the Central Coast, and we actually insist on e-referral forms from ward JMOs to access our service. And well, we've experienced some cheating going on. There's some blank boxes that we want to be mandatory, and people put gibberish in there to save time. So we see from the other side the corners that are sometimes cut. But I think to know that there's been lots of consultation from specialist colleagues to say, look, we know how time limited GPs are. These are the absolute gems that we need in terms of information. And if we consistently see that something like EDD is not entered correctly and people prefer using last menstrual period, but there's a no little asterisk there, and they're cheating on that particular section, then you guys will consider that and perhaps update the forms accordingly in time. So that's reassuring.
Sid, if I can just also add to Eloise's comment there, yeah, certainly from HealthLink's side of things, working with jurisdictions right across the country, the resultant referral forms that you're going to be using will be essentially the minimum acceptance criteria that the hospitals and the various different specialties need in order to accept and from a business perspective, accept and process that referral. There are key, and I think, Sid, I'm not sure if it was clear in the referral demonstration that you pointed out there, but there are key overrides that exist in these specialist referral forms, so that if in some way, shape or form you cannot provide key information in relation to supporting documentation, it might be additional tests or radiology, there are ways that referrers can advise the hospital of that issue in relation to, well, I know you're asking for all this information, but I don't have it today, and I need to get this referral through. So those controls do exist, just to highlight that.
Absolutely. Yeah, thanks, Josie. Any other questions?
Not currently. Any other comments from the panel?
I was just going to comment on a conversation that we had within our GP collaboration group when we were talking about how to implement this system quickly, and some of the consultation was centered around, do you just switch off, the faxes altogether straight away, and people are forced into using this system, or do you give people a little bit of leeway time to get used to the new system? And it's a nice way to trial 4 different clinics to start with before we expand it to the other outpatient services. But I think in terms of the strictness around accepting faxed referrals or emailed referrals, or referrals if the patient rocks up there with their paper copy, I think that will still be accepted for a very short time. I think the people behind this system would prefer to offer rewards through better patient care than waving a big stick over us. But I think certainly the ease of use is going to bring us all round to adopting the system quite quickly. Is that your perspective, guys, on the rest of the group too?
Absolutely, yeah. Sherry, do you want to?
Yes, thanks, Ellie. Yeah, I'd just like to echo that. What we're doing from a LHD perspective, we're definitely having a period of leniency as we've gone live. It's only been 2 days, but we're getting a lot of e-referrals coming through, which is very, very exciting. We've had about, I think it's 28 come through in the last few days, and overall we've got quite a few referrals in the system, so it's more than what we've ever expected, which is wonderful. What we will do is if we do continue to receive faxes from certain GPs or GP practices, we've got some comms prepared, and we will send that back to you every time we do receive a non-e-referral, just to remind you that we are encouraging e-referrals and we'll be discontinuing faxes. And on those comms that are coming back is a QR code and some more information about how to actually access the HealthLink forms, how to set it up in case you need any assistance, some benefits as well, and who to contact if you have any questions. We do keep a note for each clinic as well, how many GPs have sent what kind of referrals, and if we do continue to receive non-e-referrals from GPs repeatedly, we will look to try and escalate that communications back to those GPs and practices as best as we can over the next few days and weeks, and if it does continue, we might contact the PHN and see what other strategies we can do to help adopt e-referrals, and see how else we can essentially help you get onto the e-referral train.
And, I might just add, because 27 referrals in the few days that we've been live has been fantastic. We have been live with 3 other LHDs since sort of November last year, and we're seeing great uptake all around. And the more I think we progress this, the more facilities will come on, the more the case for the facilities to fund this, to expand the number of clinics across the different LHDs, and the more the uptake. So it makes your life easier in having a consistent way of referring into all the different hospitals. So yeah, the encouragement is certainly, if you keep referring via e-referrals, it'll help make the case to promote e-referrals more and get that funding and expand more. So we're already seeing that momentum, and yeah, we want to use these opportunities to promote that and drive that uptake. So yeah, absolutely.
I'll just add one other comment from HealthLink's perspective in terms of our reason for being is so that there is a auditable capability that's supported on all sides of this communication pathway that exists between your practice and any other organisation that can either you receive information from or you send information to, that needs to be managed through the interfaces that are currently already set up. So this is just one extra pathway now that will exist, all in the benefit of those referrals not getting lost again in the future, so that your patients benefit as a result.
Okay. Anyone else? No, we're all good. Okay. Well, I wanted to thank our wonderful panel. Really, really impressive, really helpful, great back and forth with the questions. So thank you to everyone who submitted questions. Wanted to thank everyone for coming. We really appreciate it. Like, this is the reason why we do these things, to get the information across. As you can see with the PHN, HealthLink and the LHD, this has been a mammoth effort to roll this out as best as we can, and the proof is in the pudding with the 28 e-referrals already coming through. So pat yourselves on the back, everyone, presenters and attendees. Good work. Thank you for coming and spending your evening with us, and thank you to the panel, and everyone, look after yourself and have a good night.
Thank you very much.
Okay.
Thank you.
Thank you, everyone.
Thanks, Phoebe.